Yeah. Hello, everyone. Welcome to everyone on the today's session of Apollo Fertility. Our today's topic is about recurrent miscarriage, and to speak on this topic, we have Dr. Suyash here with us. Dr. Suyash Bhandekar. He's an infertility specialist, an internal in-house consultant with Apollo Fertility, uh, Thane Center. What I would want to give you a brief background about Dr. Suyash Bhandekar. He's done his MS from KEM Hospital and he's done his DNB from Delhi National Board and has a fellowship in reproductive medicine. He's a well-known infertility specialist with Apollo Hospital, and he's the one who's going to talk about recurrent miscarriages and what are the things that should be taken care of. We welcome you, sir, on this session, and the session is all over to you, sir. We are
Thank
all eager to know what should be done, what should not be done, and what cares to be taken of. We are looking forward to hear from you, sir. All yours. Thank you.
thank you. Thank you so much for the kind introduction. First of all, a very good afternoon, everyone. Um, Today, we'll be talking about recurrent miscarriages or recurrent pregnancy loss. The reason why I chose this topic was like we usually have a very many couples coming into our center with a particular type of infertility, but in fact they had conceived and they had like repeated miscarriages. So does that mean that recurrent miscarriages is the same as infertility? It's no. Infertility is basically you're not able to conceive despite of 1 year of unprotected intercourse, while recurrent miscarriages or recurrent pregnancy loss is that you are able to conceive, but the pregnancy is not able to continue till 9 months, till term. So that is recurrent pregnancy loss. So, how do we define recurrent pregnancy loss? So, as per the ASRM guidelines, so whenever there is a loss of pregnancy before the fetus reaches the viable stage, and that are like more than two miscarriages, consecutive miscarriages, it is termed as recurrent miscarriage. All right. So, this is almost seen in 1 to 2% of the couples. There is another entity that is called as spontaneous abortions. So that is very commonly seen, and that is like seen in almost 15 to 20% of the couples. So maybe a couple can have a miscarriage right in the first pregnancy, or she might conceive, she delivers, and then she might have a miscarriage. So that is a spontaneous miscarriage. It is not a recurrent miscarriage. Recurrent miscarriage is consecutive more than two pregnancy losses before the pregnancy achieves the viable stage. Okay, so does that mean even after a single miscarriage, you are supposed to get evaluated from the gynecologist? No. So, but yes, in case if you have two or more consecutive miscarriages without a prior live birth, then you have to get evaluated. Or secondly, if your age is more than 35 years of age, then yes. And third, whenever you had one or two pregnancy losses without the fetal cardiac activity being documented. So there are many couples who come up with the sonography report that was like mentioning 2 or 3 months of pregnancy, but the fetal heart is not seen. So this is also a typical case that needs an evaluation. So let's see what are the causes of this recurrent miscarriages. So basically, we divide it into 4 to 5 causes. The most common being the hormonal parameters. So we have to be like doubly sure whenever you are want to get pregnant before conception. Also, your nutritional status and the hormonal parameters should be absolutely normal, especially your thyroid levels or your diabetic sugar levels. So these has to be kept into control. Second is what we have seen is like there is an increasing trend of this autoimmune disorders. So basically, these are like blood clotting disorders which make the blood sticky and thick. So this affects the placenta and the pregnancy, and that causes a miscarriage. So what do we include in it? There is a typical term called as APLA syndrome, APLA syndrome, or there could be antithrombin 3 deficiency, protein C, protein S deficiency, or it could be factor V laden deficiency. So these are all autoimmune disorders. Third, what we usually see is the anatomic disorders. Anatomic disorders by me, your uterus may be abnormally be shaped, or it might have a septum, it might have a fibroid from inside, it might have a polyp, there might be synecdoche inside the uterus, or you might have a cervical incompetence. So basically, you are fit and fine, but the uterus is not good enough to carry the pregnancy for 9 months. So this has to be evaluated. Fourth is a genetic parameter. So yes, both as a couple, you husband and wife will be like healthy, fit, fine. doing everything perfectly fine, but you're not able to conceive. Yes, in such cases, we usually ask for certain test also, and in case if there is some suspicion, we ask you to do a karyotyping. Secondly, whenever we don't get a proper sonography report, and if it is like a first trimester pregnancy loss, in case there is a term called as POC, like products of conception, we usually send it for karyotyping or microdeletion. In case if the pregnancy also suggests that there is certain genetic disorder in the pregnancy per se, then the karyotyping or the complete genetic evaluation of the couple is mandatory. And the last is unexplained, that is despite of seeing your complete profile, doing everything, despite of that there are no specific reasons that are ascertained, and that is causing a pregnancy loss. So how do we manage this particular situation? So basically, management is as per the cause. So like whenever we have a hormonal parameter, especially a thyroid, if it is hypothyroid or hyperthyroid, we have to correct. We have to maintain the normal range of your thyroid. Second is the sugar levels. There are a lot of couples who try to conceive after 30, 35, and with that particular biological age, you are destined to have diabetes, especially if your family is of a genetic linkage and you already have someone in your family with a diabetic background. So, mind you, your sugar level should be like in control prior to pregnancy as well as during pregnancy. So, these are all modifiable factors. Second is autoimmune factors. So whenever we come across that APLA syndrome is positive or any other parameter that is fitting into that autoimmune category, we have a set of medications that we can give. That is blood thinners like ecosprin or low molecular heparin, depending upon what cause it is. And that might be needed for complete 8 to 9 months also. Third is anatomic factors, which I mentioned. Yes, you are completely fine, but yes, in case if we come across while doing hysteroscopy that your uterus has a septum or a polyp or a syncytium, that needs correction. So basically, hysteroscopy is like seeing inside the uterus with the help of a small camera. There is no cut or no stitches at your private part. We directly introduce that small camera, 2.9 millimeter camera, inside the uterus through your cervix, and then we visualize the complete cavity. So in case if there is some space occupying lesion, that is going to impair with the overall growth of the pregnancy. So especially if there is a septum that requires a septal resection, or in case there is a submucous fibroid, type 0, type 1 fibroid, which might interfere with the pregnancy, that requires a removal. Another factor that we usually come across is like, especially with a couple who had like multiple miscarriages and they had undergone a DNC. So there could be some syndicate that usually forms inside the uterus. So even that is going to interfere with the implantation and the overall growth of the pregnancy. Fourth is the cervical incompetence. The typical history of cervical incompetence is there is a second trimester miscarriage that happens. Usually, all of a sudden, there is no pain, but all of a sudden, the lady feels there is a gush of liquid or a bulge that is coming out from the vagina, and within hours, she aborts. So, this is a typical history that a cervical incompetence presents with. So, either what you can do is at the right time, you can put a cervical stitch, or you can do an internal circulage. That is like before conceiving, you can do a laparoscopic internal circulage, just put a stitch at the level of the internal loss. So even that will help you to avoid the pregnancy loss that might happen in the second pregnancy. All right. Fourth is the genetic factor. So, unfortunately, there are couples who have some genetic issues, and some may have to go undergo some genetic testing also. So, does that mean that they cannot conceive with their own biological child? No. We have a very good option as of now on the card, that is a pre-implantation genetic testing. So, basically, before doing the embryo transfer, that is an IVF, we usually see how is the genetic makeup of the embryo. If it is a euploid, that is a normal embryo, only in that case we are going to transfer the embryo inside the uterus, and that is going to give you a good pregnancy. In case if we have abnormal embryos, genetically defected embryos, we cannot transfer them, because this is going to give you another miscarriage. So the PGTA, that is a pre-implantation genetic testing, this is going to help you, especially in cases of genetic disorders that have been detected. In case if there is a family history, yes, you have some genetic issues in your family. Even in that cases, we can do that PGS, that is pre-implantation genetic screening. And the last is unexplained. Unfortunately, whenever we come across such patients, it's actually very disturbing, and these couples require a lot of psychological counseling and motivation. But yes, fortunately, almost 50% of these couples do conceive spontaneously, and with all the empirical therapy that we give, they are able to continue the pregnancy as well. So roughly, I would suggest yes, recurrent pregnancy loss is completely different from infertility. We have to find out the cause for it, and yes, once the cause is established, we have to correct it. So that is going to give you a better pregnancy outcome. With that, I would suggest I have almost covered a bit of it. So any questions from your end are most welcome, and I'll try to answer it at the best of my possibility. Thank you. Yeah, the question is from Arti. She is asking, is recurrent miscarriage considered infertility? As I rightly mentioned right in the beginning, infertility is completely different. Recurrent miscarriage is different. Infertility is like not able to conceive only. And recurrent miscarriages, like yes, you conceive, but you're not able to continue the pregnancy for 9 months. So that is different. Okay, another question. Are there any effects on the ovulation cycle after recurrent miscarriages? Apparently, there shouldn't be any effect on the ovulation cycle with this particular entity. The only thing is, yes, in case if your hormonal parameters are to be blamed, in that case, yes, your overall menstrual cycle or the ovulation cycle can be disturbed to certain extent. But the other parameters are not going to affect your menstrual cycle, apparently. Okay. Another question is like, what nutrition should we have after the miscarriage? Um, See, as I mentioned, your preconceptional nutritional status is really important. So, right from your multivitamins to your protein intake, your overall fitness, if you're like morbidly obese, then definitely you have to reduce your weight also. Even that particular thing, yes, in case if you're overweight or obese, even that was going to cause you miscarriage. So, overall nutrition point of view, you should be taking care of your diet and exercise right from the preconceptional part. And after the miscarriage, we usually don't give any particular nutritional supplement. The only thing what we can explain is like maybe if you have a had a like a really bad blood loss, in that case, yes, maybe some iron or calcium supplementation and some protein supplementation can be added to certain limit. Otherwise, we just have to see what vitamin deficiency is there, like vitamin D or vitamin B12 deficiency is there, and then we can give you a supplement accordingly. Next.
There is a question which says, what food items should we include primarily in our meals?
Yeah. Food items, I would say you should have a balanced diet. That means, yes, your carbohydrate, your fat, and protein intake, everything matters. Especially, we have noted this in vegetarian couples who are like completely into vegan food or vegetarian food. They lack in that B12 deficiency. So for that, yes, you can take some supplementation. Like there are multiple multivitamins that are available over the counter. You can just take them. Secondly, is the vitamin D deficiency, which has been like really really common. With this particular era, we are usually sitting in the offices in the ACs, and there is hardly any exposure to the sun. So the vitamin D deficiency is because of that. So you might take vitamin D supplementations as well, provided you are proven to be deficient. Even excess of vitamin D is going to cause you a problem. So yes, vitamin D, vitamin B12, your overall nutrition has to be maintained. Try to include a lot of vegetables and salads in your diet. Fruits has to be taken on a regular basis, and primarily make sure that you have a adequate water intake also. Like roughly around 2 to 3 liters a day is the required amount that we usually suggest. Okay, there is another question that how should we keep ourselves emotionally and mentally stable? Um, yeah, this is a very tricky question, I'll say. See, these couples are actually very much tensed and in agony because they have faced almost like 2 or 3 miscarriages, and it is our job not to have a repeat miscarriage with the same thing. because we don't want them to land up with the same experience which is going to give them more trauma. It's more of physical and mental trauma both. So it requires a lot of counseling. And secondly, the only thing which is going to give them a bit of relief is, yes, once they conceive and they're able to conceive the pregnancy for 9 months. So that particular thing, yes, you have to take help of a psychological counselor, and the couple as such should be like really strong. We usually ask the husbands to be like uh, pampering their wives accordingly, because see, it's a very difficult job for a girl to handle such things. It's not only a physical pain; it's more of a mental and emotional trauma that she's undergoing through. So, for such patients, we usually suggest them not to conceive till we arrive at a particular cause for it. And once the cause is established, try to resolve it. And only then we give a signal, yes, now you are able, yes, you can conceive, and then we can help you with continuing the pregnancy for 9 months. So that is how we usually approach for such patients. Okay. Does any comorbidities affect ovulation cycle and result in miscarriage, recurrent miscarriage? Yeah, as I mentioned, in case if you have like hormonal issues like thyroid, or you are like morbidly obese, your weight is like almost 90 or 100, and you are diabetic, on insulin, or on oral hypoglycemic agents. So these particular are going to affect your menstrual cycle definitely, and they are also known to cause you recurrent abortions. So the primary aim is to correct these particular comorbidities. Give them time. Maybe they can take a 6 month, 8 months. Once they are back to normal, then you ask them, yes, you are ready to go ahead with the pregnancy planning. Okay, I think those are the questions. With that, I'll just like to brief up my topic. So, first all, infertility is completely different, and recurrent miscarriages is completely different. Recurrent miscarriages is like you are able to conceive, but you're not able to carry the pregnancy for 9 months. There are multiple reasons behind it. Yes, please visit a gynecologist or a fertility specialist who can resolve to your concerns. And yes, a right direction is needed every time. So try to get a right direction in which way you are going ahead. And secondly, there are no shortcut to do this. You have to follow the step by step approach only. Once you get the particular step, yes, this is a problem, try to resolve it. Once that is resolved, yes, you will achieve your pregnancy and ultimately success. So with that, I'll wish you all the very best, and thank you so much for your patient listening. Thank you very much.
Thank you, sir. Thank you so much for your session. It was really wonderful listening to you. Thank you. Thank you once again.
Thank you.